Hello and welcome to the Healthcare Today podcast. Our guest today is Vanessa Emslie, Chief Medical Officer at women's health and longevity company Willbe. Today we're taking a precision medicine approach to perimenopause, talking about the rapid change in the adoption of hormone replacement therapy, shifting clinical barriers, and the revolving door of patient attrition. In an article you wrote for Healthcare Today, you highlighted a striking statistic: 40% of women discontinue HRT within the first year. Why is this?
I think the challenge is that every woman goes through perimenopause very differently. There are many pieces of the puzzle. One of those key pieces is obviously your genetics. Genetics underpin how we process hormones, how we balance hormones, how we metabolize them, how we eliminate them from the body. As well as then you've got, lifestyle choices and all of those other things I think we're all very familiar with. But what happens is that women, especially in hormone health, have complete kind of opposing or reactions to hormones. Some women, just with a normal menstrual cycle will have different durations. Some women will have a lot of period pain. Some women don't. Some women have PMS, some women don't. And when you think of the reactions that women have during just their normal menstrual cycle, fertility, that translates again into perimenopause. And so when women are given a standard protocol that is deemed as safe by various regulatory bodies, there are a lot of women that just simply don't respond in the way that they're hoping for. So a lot of women come to HRT, they're hoping to feel better, they're hoping to feel like themselves again. And the reality is that for a lot of them, either the HRT doesn't work sufficiently enough for them to have that I feel like myself again response, or the kind of complete 180 to that is women try HRT and it actually makes their symptoms worse, and so they stop. There's multiple versions of it. You have a slightly higher rate of stoppage within the first 6 months, but on average it's around 38 to 40% within the first year.
You've mentioned that these women leave feeling frustrated and broken, convinced that HRT just doesn't work for them. Why do you think that emotional response is so common?
Because they're frustrated. So I think the first thing is HRT is often sold as this is the magic pill, this is the magic treatment, this is going to make your life better. And so often by the time, so the statistics for the UK is that women spend 2 to 4 years trying to seek clarification of their hormones or their symptoms, that it's hormone related, perimenopause. And they've already tried quite a lot of their own solutions. So whether it's lifestyle or supplements or, chatting to friends, getting support from their peers or their sisters, and then nothing's worked. So after 2 to 4 years of being super frustrated, feeling like they're not getting anywhere, they finally get to their nurse practitioner or their GP, and they said, okay, fine, we'll now give you HRT. Everyone gets excited, and then of course the letdown is quite significant from that when it doesn't work for them.
Now, as the Chief Medical Officer at Willbe, you've helped to identify 3 genetic archetypes. So, correct me if I'm wrong here: hormone responsive, hormone sensitive, and hormone silent. How did this classification system emerge from your work?
So it came when we were struggling to actually help women understand what was their ideal HRT dose. Did they need to go maybe slightly lower than the norm or slightly higher than the recommended norms? And also, why would I have, multiple patients who were pretty much the same hormone levels when I tested it, and then I'd give them, based on that, the same hormone therapy dose, but I would have 2 opposing reactions. I'd have a client who'd loved it, and I'd have a client who said, no, I need to stop. And so my background is actually in nutrigenomics, and then we started going into the world of, hang on, there needs to be something more. There needs to be other answers that are lying within this kind of reaction space. And so we did a lot of work for about 2 years on understanding the genetics that go into the genes and the epigenetic effect on hormones and how this can then kind of help us to categorize women into somebody who's responsive. So this is the woman, and I'll explain them. This is the woman who will go to the GP or a nurse practitioner. She will get, based on her symptoms, a standard dose of HRT, and in all likelihood, it will work pretty well or it will work brilliantly, but it will work well enough so that they stay on it. Then we find that we work a lot more with the two kind of opposing sort of arguments. The one is the woman who's hormone sensitive. Her genetics make her very, very sensitive to hormones. She often has a lot of mood issues, often with a history of like things like PMS, PMDD, so post-perimenopausal dysphoric disorder. And this woman, you give her a standard dose and it's too much. Her body cannot cope. She needs to go much slower, much smaller doses, and also looking a lot more at how we support her genetics, her detoxification pathways. And then the converse is also true, that we'll give somebody a normal dose and they don't respond at all. And that's simply because they are what we classify as hormone silent. Their bodies need more neurotransmitter or cortisol support so that the hormones actually can work well without us going into very high doses that could potentially be harmful when we go off label.
Now, talking about the hormone-sensitive patient who experiences anxiety from standard progesterone doses, seems particularly counterintuitive. Why would a therapy meant to calm actually trigger symptoms?
So this is the one area which is we have a lot of interesting discussions on. So progesterone down the pathway makes allopregnanolone. Allopregnanolone is a precursor, or it kind of leads on to GABA. GABA is a neurotransmitter. It is a central nervous CNS, or central nervous stimulant, but it actually is a calmer. And when women take progesterone, the kind of anecdotal phrase for it is it's the chill pill. It is the chill hormone. And that's because of that allopregnanolone response. And women find it when they haven't got enough progesterone and we supplement it and they are responsive, they sleep really well, their mood calms, and that's because we've got this lovely allopregnanolone and GABA effect. However, with some women, their genetics predispose them to having very, very high levels of allopregnanolone. So their pathways really ramp up pregnenolone. And that can then be too much for the body to cope with. And instead of it having a calming response, it actually can heighten their sense of anxiety. Progesterone they take at night, expecting it to help us sleep, which is one of the main functions of progesterone as a therapeutic intervention. And they actually find it's the converse. It keeps them up at night. And that's because we've got too much allopregnanolone. And so that's this sort of progesterone dichotomy where we're expecting one result and it gets another one.
So from another unexpected result, perhaps for the hormone-silent patients who clear hormones too rapidly, how do you distinguish between a true non-responder and someone whose genetics are simply just working against them?
For somebody like that, what we would do then is we do genetics and we obviously do a deep dive into the hormones. So it's not just a blood serum test, we look at urine testing, and the reason for that is your urine testing captures the metabolites. And then we start looking at things like metabolite ratios, so how they are in balance with each other. And then we're looking to see where do we see the overlay of the genetics actually influencing what's happening on the ground, in the blood, or in the bloodstream, in the body. And from there, we can look to see somebody who classifies as silent. We'll probably see that they'll take progesterone, for example, but they aren't actually making allopregnanolone. And so we then need to see what epigenetic or nutrigenomic factors do we have at hand, and there are many. What can we use to kind of gently push that body in the right direction so that we combine sort of lifestyle nutrigenomic solutions as well as hormone replacement therapy in tandem, so that it supports the genetics as well as then looking at how do we have healthy, optimal, safe doses of HRT for that woman.
Genomic testing is becoming more accessible, but many GPs still don't order it routinely. What would be your pitch to a busy clinician about why this should become standard practice in perimenopause care?
I think the first thing is obviously there's a cost, and when it is a NHS provider, those tests are not routinely considered. When you're in more private healthcare, obviously they do a wider depth and breadth of testing. So to those providers, my sort of discussion rather than argument to them is to say it's a once-off test. When you know what you're dealing with, it helps you to shortcut that woman's journey. It helps you to quickly identify what their potential perimenopause symptoms could be driven genetically. And then it also allows you to look at the detoxification pathways, so you know immediately this woman is going to be more predisposed to, say, a higher estriol and high 16-OH metabolites. And so it allows them to quickly choose the correct hormone replacement therapy at the beginning, so that we don't do 6 months of this formulation and it didn't really work, we didn't see the impact, and then we change the formulation or the therapy or the dose and we still don't see it. And that's where also the frustration comes in, is that women say sometimes, oh, you're always changing my doses. And the perception is then that the practitioner doesn't know what they're doing. And it's not that at all. It's just that we're trying to figure out which combination works for you. When we know your genetics, it helps us to quickly bypass some of that sort of trial and error in a very clear process, as well as it gives us proof to the patient or the client to say, we can see from your genetics that for you, you need to implement these lifestyle changes, cut your alcohol, do your exercise, because if you don't, the HRT could be alleviating your symptoms, but it could actually be potentially placing you at higher risk of cancer or inflammation because you're more prone to those conditions because of your genetics. So it also gives us tools to help the client quickly adopt those lifestyle practices, which are critical to the success of hormone replacement therapy.
Talking about those tools, you've mentioned specific nutrients like methylated B vitamins and quercetin. Got that right?
Yes.
How should clinicians think about incorporating these alongside HRT?
That's where genetics becomes really a critical part of the puzzle. I think we all know you can go to any health shop, any online supplement store, and there is a plethora and laundry list of supplements that are good for perimenopause, never mind all the other sort of conditions out there and sort of health goals that women and people have. I often say to people, why are you taking these vitamins? Why are you taking this mineral? Why are you taking these botanicals? So, for example, like ashwagandha. And half the time, they don't really know. So when we look at genetics can quickly pinpoint for us. We know that this person and sitting in front of us, whether it's male or female, should actually be taking B vitamins. They have genes that don't methylate well. So methylation is a very critical part of detoxification, as well as our bodies, turning hormones and epigenetics on and off. And if you don't have some of the optimal gene alleles or signatures, for want of a better expression, you may need methylated B vitamins to help your body methylate well. And that helps you to live longer and better. And so when we know your genetics, we can pinpoint quickly, do you need vitamin D3? Do you need vitamin K? Do you need B vitamins? Do you have issues with detoxification? Do you have issues with glutathione? Do you need more antioxidant nutrient support? And when we know genetically what your body likes and needs, we can quickly stop, people from investing thousands of pounds at health shops, which actually are not helpful for them at all. So that's where genetics can really help to narrow down supplements and epigenetics.
I mean, apart from, talking on podcasts like this, how do we get this message out there? Because it seems fairly straightforward. If you have the tools, you know how your body works, go that way. How do we get this message out there?
I don't know. It's great. I think it's great to have this opportunity, and thank you for letting us, come into the podcast, because it just helps us. We do a lot of talks, we do a lot of webinars. We are obviously trying to talk to clinicians quite a lot. I think also one of the biggest barriers with genetics is because it is all overwhelming and all consuming. Sometimes, even though we do try and simplify and strip out the key action points, perimenopause female-focused genetics report is 60 pages long. That is a really long document. Not everything is applicable because your genetics may be good in certain areas. But even then, just on that topic alone, we are trying to simplify it. For people who don't have a good science understanding but want to be healthier, the minute you start getting into genetics, there is that sense of overwhelm. So I think the first thing is, it's always try and do the most, 3 key things. Don't try and do everything at once. So I think that's also a key barrier we need to overcome. And genetics is a once-off test. So you do it once, and then you can always refer back to it as you transition through your perimenopause journey, as you get older. We also look at things like osteoporosis risk, cardiovascular disease risk, Alzheimer's, because those are chronic diseases that really elevate as women age. And that's because of that hormone drop as well. They're very closely interrelated. But yeah, webinars, events, speaking, social media, we do a lot. We try our best.
What would change about perimenopause care if every woman had her genetic profile mapped before starting HRT?
So we would reduce that 2 to 4 years probably to a space of about 6 months. So that would be one thing. The woman would be empowered for her own self to know what her symptoms genetically are driven for perimenopause, so she can also anticipate when her responses, are they perimenopause or is it something else? Because I think that's also the challenge women have, is the symptoms for perimenopause overlap with so many other conditions that they're not always sure, as well as it allows women to take ownership and feel comfortable with their bodies at a time where traditionally the view has always been, I don't know what's wrong with me, I don't know what it is it perimenopause, isn't it? And so I think, it allows the doctor to be very focused, give them the right support at the right time quickly without trial and error. So that also helps to improve the client-patient relationship and the trust that the patient experiences with the doctor, as well as then the patient feels empowered that she knows how to work with her body, and she feels supported and can advocate for herself as well with a lot more confidence.
I mean, traditionally, doctors, when women reach a certain age, have just said, oh, it's that time of life, the language that they used to use. Things are changing now. Obviously, they're moving in the right direction. But what's one thing that you wish every GP knew about prescribing blanket HRT that they're not currently being taught?
It would be genetics, and it would be for them to embrace and learn about genetics. So even if they weren't in a position to test genes, if that was not part of their testing repertoire in their clinic, that they would at least be able to assess a woman and to then anticipate that maybe genetics, what's causing this response to HRT, so they can then look at potentially, the symptoms the woman's having, their reaction to HRT, and then almost kind of like backtrack and figure out, well, maybe it's sort of this sort of area, this gene, and they could then maybe look at other ways, other HRT, instead of just stopping it. Because I think that's the thing is, and it allows them to also talk intelligently to a woman to explain why the HRT is failing or why they are needing to change the formulation.
Dr. Vanessa Emslie, thank you very much for your time.
It's a pleasure. Thanks for having me.